Thank you very much, Dr. Dukas. It's a pleasure for me to be here today. Ever since I've been involved in bioethics, one of the most interesting things to me is how physicians think about the law. Starting my career in law and then moving to bioethics is, I suppose, primarily responsible for that. And I've focused, for the most part, on end-of-life decision-making and the ways that perceptions of law can color the interactions between physicians, families, patients, and other healthcare providers. And so what I'd like to do for you today is discuss briefly two phases of some long-term research that I've been doing, present state-specific results from each of those, and compare them for you. And then at that point, I hope we can draw some lessons that can be useful for other states as well. So when I start talking about New York and Texas, I hope I don't lose you, because I think we'll find some commonalities that can be useful for every other state as well. And the big question is that we've been talking about end-of-life issues in bioethics for over 20 years, but yet concerns still persist in the medical community about the impact of law on medical decision-making. And a colleague of mine at Duke, Dr. Jeff Swanson, and I have been working on this for a considerable amount of time. And we published a study in 1992, which was essentially based on my doctoral dissertation, investigating this topic among Texas physicians. And so that's where I'd like to start the introduction. Our previous study found that about 25% of the physicians that we looked at adopted a posture that we're calling extreme legal defensiveness when they think about decision-making for dying patients. So the first point to note is that there's bad news. There is this quarter of the population that has these attitudes, but there's also very good news in that 75% of those we studied did not have those attitudes. So I'm not generalizing to physicians as a whole, but there is this subgroup who seem to behave in different ways, and those are the ones of interest to us. We also found that the most defensive physicians, as we measured them, were the least knowledgeable about the law, because we not only asked them what they thought about their risks, but we also asked them what they knew factually about the law in the state where they practiced. And we found that the higher they scored on a test of law, the less likely they were to fall into this 25% of extreme defensiveness. So a logistic regression model that Dr. Swanson has put together predicts that as those very defensive physicians would learn more about the actual facts of the law that apply to them, that they would be less defensive. We don't have actual verified evidence of that, but the models all do suggest that education can have a beneficial effect. So what are we talking about when we say legal defensiveness? We're not thinking just about legal defensiveness in terms of defensive medicine, as you might think of it. Medicine doing things or not doing things just for the purpose of avoiding a possible legal claim. We're including in this a broad socio-psychological aspect, including general levels of concern about the effect of law on the lives of physicians, both with respect to criminal and civil law, as well as general worries about just sort of their ability to practice. Our earlier study also asked interesting questions about their religious background and religious practices and things like that. So we're trying to establish sort of a global measure of this defensiveness. Those softer aspects didn't really produce much reliable data, so we're left with the other aspects. So those are the ones I'm going to focus on today. Nonetheless, the psychological dimensions, I think, are realistic and do play a role, but they're much harder to tease out. So the central problems, as we see them, are this. Legal defensiveness may substantially influence medical decisions in ways that, A, undermine patients' rights to determine what happens to their own bodies, and also may affect strongly the ability of family members to implement patients' preferences once the patient becomes unconscious or lacks capacity. Frequently we see that even though the patient was very clear in what he or she wanted, the healthcare providers will maybe continue to offer treatment that the patient clearly didn't want if the family requests it or demands that it be done. We also believe that unreasonably strict laws can exacerbate physicians' legal defensiveness. That is, if you're in a state that has crazy laws or laws that are highly restrictive, you're more likely to do things in reaction to them. So we're concerned about that, and that will play a big role in the material I present about New York in just a few minutes. And most importantly, there's a patient-centered aspect to this, because we believe that legal defensiveness may reduce quality of life for critically ill patients near the end of life by precipitating treatment that they would not have wanted, and by possibly generating unnecessary family conflict. So for the New York study, which is the general focus of this PowerPoint, but I'm going beyond, we decided to replicate the major portions of the Texas study to try to generalize our findings outside Texas, and then ascertain how the New York legal environment affects these same types of issues there. And as you'll see, the New York legal environment is very, very different. New York has essentially the strictest legal environment in the country on the right to refuse treatment, and that's based primarily on one case from the New York Court of Appeals, which is the highest court in the state of New York, the case of Mary O'Connor. And I'll discuss that in a little bit of detail in just a few minutes. First, a little bit of information about Texas. Texas has a state statute allowing family members of a patient to make medical decisions for that patient, even in the event of incapacity and under advance directives. The priority of decision making, if the patient lacks an advance directive, is explicitly mentioned in the statute. So if you become incapacitated in Texas and you've not executed an advance directive appointing a person to make decisions for you, the law will actually step in and offer a priority system whereby physicians can feel comfortable that that person identified under the statute has legal authority to make decisions for the incapacitated patient. If the family member is not present, if you run out of people on the priority list, the statute also includes a best interest standard whereby the healthcare team can use best interest to decide what should be done for the patient. New York has no statute that resembles this in any way, and case law does not recognize a best interest standard in New York. So the only way to get a decision made by proxy in this case is by executing a formal advance directive, appointing an agent, and it's particularly important that this happen in cases of artificial hydration and nutrition. The only relevant law in New York, other than the DNR law, which is really only limited to resuscitation issues specifically, is the healthcare proxy statute in New York, which, as I said, allows a patient, while capacitated, to appoint another person as agent for decision making. Now, I'll give you a little bit of background about the case of Mary O'Connor. Those of you who are lawyers, I'm sure, are familiar with it, but the physicians may not be. In fact, I sort of hope you're not, because it tends to raise people's anxiety level. Mrs. O'Connor was a 77-year-old woman after repeated strokes, had multi-infarct dementia. She was unable to spontaneously swallow food and water. She had substantial cognitive impairment. It was clear that she lacked decision-making capacity. But she did have waxing and waning consciousness. Occasionally she would be able to respond to simple commands. Other times she was completely unresponsive, and she vacillated between these states. Her condition was diagnosed as irreversible by a number of neurologists with no substantial hope for recovery. The physicians, she was in a skilled nursing facility. The physicians there sought permission to insert an NG tube when she became unable to swallow. Her daughters refused to consent to the insertion of the tube. She did not have an advance directive of any sort, but she had had conversations with her daughters, and we'll talk about that in just a second. The hospital then went to court over the daughters' objections to get a judicial order to insert the NG tube. The daughters testified at the hearing that their mother had repeatedly stated her wishes to refuse medical treatment under circumstances similar to those, but she was very vague when she described them, saying that it was monstrous to keep someone alive using machinery and things like that when they're not going to get better. So it was pretty clear what she wanted, but she didn't specify, if I have multi-infarct dementia, this is what I want to refuse. And as it turned out, that was her big problem. Little did she know. Well, the Court of Appeals in New York ordered the insertion of the tube and determined on their basis that the evidence of the daughter's testimony was not sufficient to allow them to refuse the tube. They stated that it was not clear and convincing, which is the standard of evidence required in New York. And they stated this rather pointed fact. There must be proof that the patient held a firm and settled commitment to the termination of life supports under the circumstances like those presented. Notice that, under circumstances like those presented. They then went on to say the trier of fact, that is the judge or jury, must be convinced as far as humanly possible that the strength of the individual's beliefs makes a recent change of heart unlikely. Now, if you're familiar at all with the standards of evidence, you'll know that there are three that are generally applied. The civil case usually uses a standard known as preponderance of the evidence, which is just 51%, more likely than not. The criminal law requires a proof beyond a reasonable doubt, while clear and convincing evidence is somewhere in between, and it's not entirely clear as to where that line is drawn. But to me, saying something like as far as humanly possible suggests really that the court is thinking more along lines of beyond a reasonable doubt than clear and convincing. So they're at best using a highly subjective interpretation of this, that we have to know what this patient would have wanted under these circumstances. This has been noted by some authors as sort of a pure subjective intent interpretation of clear and convincing evidence. It's the narrowest interpretation of any state in the country, and unfortunately it's still the law in New York. I won't read this quote to you, but the manual that New York lawyers use recognizes that if a person doesn't have a healthcare proxy, there's nothing anybody can do to refuse, especially to refuse food and water under cases like this. This case has been roundly criticized by a number of legal and ethical scholars, but is still current law in New York. Now, just a little bit about our methodology for the study. We studied 2 tertiary care centers within the state of New York, one our own SUNY Stony Brook system, and then also the State University upstate, which is at Syracuse. Both of those are teaching facilities, tertiary care centers. The populations we studied were surgeons and internists, and we got a few neurosurgeons because they were in a separate department at Stony Brook. I have no idea why neurosurgery is a separate department there, but New York has its own ways. We excluded from the study population first-year residents because we felt that they would lack sufficient experience to really claim what they do and how their practice was affected by these types of issues. The New York instrument that we constructed was a questionnaire, 37 items. It included, as the Texas questionnaire did, 10 questions asking them relevant aspects of New York law that are based on factual things that they should know in order to practice. One of the questions we asked was essentially one that required them to interpret the O'Connor case and use it to answer the question. So there is a question based on that case. As a result of this legal questionnaire, we constructed a score generally that was based on 1 to 10. So you could get a score from 0 to 100 depending on how well you knew the law. And we arbitrarily chose, as we did in Texas, the same cutoff point, which is if you got 7 out of 10 right, we consider that a passing score. At least we divided the population in that way. There were a couple of statistical modifications that I'm not going to go into because you'll get really bored very fast, and I want to avoid that. You do need to know a little bit about our scale, though, because in order to measure legal defensiveness, we have a number of questions that were the same on both the Texas and the New York studies, and those are included in your handout. If you look at Table 1, you see the example of the questions that are used in the defensiveness scale. Questions about how often do you perceive that the law requires you to perform medical procedures on a terminally ill patient? When you think such procedures are medically inappropriate. And we asked that both regarding civil law and criminal law. And a number of other questions were found to load on the same factor, if you understand statistics. These questions were all found to be essentially asking the same question, and they were answered in the same way. So our statistical expert, Dr. Swanson, recoded all this and processed it, and we found that essentially we were using the same questions. Here's Table 1. I like for people to be able to have the handouts to look at these because there's a lot of detail in there, and I don't want to go through it all individually. But you can see that that's the entire list of the 5 questions that produce our measure of legal defensiveness. Table 2 is just a sample of the types of questions that we asked about factual law. These questions weren't designed to be particularly tricky. They were just designed to elicit knowledge of the law, although you did have to have knowledge of the law in order to answer them correctly, of course. So that's an example of those. And question 2 is the question that was based on the O'Connor opinion, which I just described to you. A healthcare agent's decision to refuse artificial nutrition and hydration for a patient may be honored only if the patient has indicated that he or she wishes to decline artificial nutrition and hydration. The answer to that is true in the state of New York. So in order to decline food and water, you have to have talked about it with your agent. And that agent then has to tell the healthcare providers that you talked about it and what the substance of that conversation was. So question 2 was a measure of their knowledge of the O'Connor decision. Just a couple of points about distribution and response. We had 426 questionnaires at both these institutions. We did 2 follow-up rounds. We got 180 completed questionnaires and had a response rate of about 42%, which people who survey doctors routinely tell me is a pretty darn good response rate for physicians, especially when we weren't able to pay them any money or offer them a boarder's gift certificate or something like that. So the response rate in New York was actually slightly higher than the Texas response rate, but they were comparable. So what did we find out about these New York physicians? First, they did a little bit better on the test of law than their Texas counterparts. As you see, the pass rates in Texas, Texas was 22.9% and New York was 30.8%. By specialty, the data were similar in that internists did better than surgeons. They were more likely to do well on these tests. The mean score, however, did not vary significantly at all, which is sort of the bad news because you see it's mean 55 in New York, 54 in Texas. So the average person answered 5 out of 10 correctly. So that's probably not going to get you too many passing grades on tests, but it's a short test too. The New York physicians' performance on the law test was not associated with their source of information. And this was different from our Texas results. One of the most interesting things to people who have read our Texas paper is that we found in Texas that our physicians who reported that they got none of their information from other physicians scored dramatically higher on the law test. And we could not duplicate that in New York, which I found somewhat disappointing, but it's still rather interesting. But I think it does confirm the pernicious effects of the medical gossip mill to some extent. So that can also play into the psychological factors, I think, in legal defensiveness. So let's look at a distribution of the varying legal defensiveness scores in Texas and New York, and that's found in Figure 1, which is on your handout also. You can see that they track pretty closely The mean is pretty far to the left, and then there's this long tail to the right. So the mean is those physicians who weren't particularly legally defensive, and the long tail on the right is those who were extremely defensive legally. And then there's a cutoff point whereby we arbitrarily determined the point that we would call extreme. That was based on some statistics that Dr. Swanson did as well. So there was no real difference in defensiveness on these data. However, we found that when the knowledge of law is taken into account, the results showed a very marked difference. In aggregate, the New York data show an inverse relationship to the Texas data. That is, in Texas, passing the law quiz was associated with lower legal defensiveness, while the aggregate New York data show that passing the law quiz was associated with higher legal defensiveness. This, when I first heard the results, was sort of a moment of panic. I was thinking, oh, expletive, what's going on here? But then Jeff and I sat down and thought about it and said, I wonder if we could look at the data a little bit more. And so he went back into SAS and did an excellent job of actually finding out what was going on here. There's the color picture of that. I think we can skip that slide. This is the aggregate data that I was explaining to you a moment ago, where you see in Texas on the left, low knowledge of the law produces high defensiveness, higher knowledge of the law produces lower defensiveness. In New York, the bars are just reversed, you see. This was a real puzzler for a while. So what we did was said, well, New York has this crazy O'Connor case, so I wonder if that could be affecting our data. And indeed, we found that it was. So what we did was isolate question 2 that I read to you a moment ago, talking about the O'Connor decision. And we looked at the group of respondents in New York who, A, passed the law quiz in general and got question 2 correct. So we have a subset of our subset, and we're colloquially calling this crowd the legal experts in order to have a shorthand way of referring to them.
Can they put that on their CV?
Yeah, probably. we give a little certificate, actually. So this group of legal experts were actually found to have the highest degree of legal defensiveness of everybody that we studied. In fact, not only did they have the highest, but they accounted for 100% of the variation between the Texas and the New York data. So when you take these people out of the analysis, the association between legal defensiveness and knowledge of law is essentially the same relationship in New York and Texas. That is, again, as they learn more about the factual law, they are less anxious, less legally defensive. So we were quite comforted from that, to say the least. Okay, I've already said that essentially. And this shows the New York data as parsed out with the legal experts in their own category. So you see low knowledge of law, higher defensiveness, medium knowledge of law, lower defensiveness, knowledge of the O'Connor case, very high legal defensiveness. So this was really quite interesting to us, because that was one of the reasons that prompted me to do this study, was that I was aware of this case and how it affects our practice clinically in New York, and I wanted to see what the data would look like. This information is telling you a little bit about our logistic regression model that shows that there are significant effects between legal defensiveness and knowledge of law, and it's way more than everybody wants to hear, I'm sure, but it's in there, and you can read the published article if you'd like to go into that in greater detail. But let's go ahead and summarize instead. So in general, we found that New York and Texas physicians report similar attitudes in practice, when you consider how state laws affect decisions for incompetent patients, and that as knowledge of law increases, concern about general legal issues decreases in general. However, our legal expert group suggests that this subgroup of physicians are knowledgeable about the particularities of the law as constrained by the O'Connor case, and that they react very strongly to those constraints. And I would submit to you that that's actually not irrational at all. If they are out to get you, you're not paranoid, right? So it's unfortunate, but it's an accurate portrait, I think. The big problem is that this finding, I think, has negative implications for patients in New York who want to have their wishes to refuse treatment carried out if they don't have a healthcare proxy document. So essentially we found that New York's very strict law imposes a substantial barrier to family decision making in cases where there's no advance directive, and that the O'Connor court's standard, this highly subjective standard, means that stopping treatment is really only permitted for incompetent persons who lack healthcare proxies when the decision makers can be virtually certain of the wishes of the patient under the same medical circumstances. Now, I view this as sort of like asking them to read tea leaves. You know, you have to predict how you're going to die and under what circumstances and what treatment will need to be stopped, and it's a completely unreasonable implication of that law. So essentially this means that if you follow the New York law, stopping treatment, especially stopping hydration and nutrition, is going to be very difficult, even unless you have a proxy document or unless the patient was exceptionally clear, which almost never happens. Now, New York has been trying to solve this problem for over a decade. In 1992, Governor Mario Cuomo called together a task force to report on this problem and others like it and propose model legislation for patients lacking capacity. It was a multidisciplinary task force, multi-ethnic, multi-religious, very broad brush, very broad-based group. And they came together and made a number of good recommendations, which the center of which was that they recommended that the New York legislature pass a law similar to Texas, which appoints a priority system in the event patients don't have advance directives. Keep in mind that about 25% maximum of the population has an advance directive. The data go as low as 10 or 12%. It's highly variable depending on which study you look at, but it's not more than a quarter of the population. So most of the people in the state are out of luck in this case. So the task force advocated establishment of a legislative process that would deal with this. And this was incorporated in a bill known as the Family Health Care Decisions Act. This bill has been filed in the New York State Assembly every year since 1992. It's never passed. In fact, only in the last session that concluded in the spring of 2006 was the companion bill even introduced in the Senate. So we viewed that as major progress, the fact that we could get a Senate sponsor for a bill. It's another entire lecture to discuss with you the horrible dysfunction of the New York legislature, but suffice it to say that it is virtually dysfunctional and doesn't do anything because essentially the governor and the speakers of the two houses make all the decisions and they just tell everybody else how to vote. So if you can't get agreement between all three of those people, you don't get any legislation. It's really bizarre. At any rate, Joe Finns, who some of you I'm sure know, who's at Cornell in New York, wrote a very pithy commentary in the Albany newspaper a few years ago, and he said this: the inadequacy of our state's end-of-life decision-making laws will not be apparent to most New Yorkers until it is too late. And I think that sentence really sums up the problem. People don't follow this type of information, and then by the time you learn about it, you realize that you can't do anything about it because the patient lacks capacity to get the needed documentation. So this is where our New York presentation would end with a plea for passing this legislation, but it leaves us here in Kentucky asking a question, well, of what relevance is this to us? Well, I think that it's both good and bad news. I believe that the general trend of the data shows that, at least to some extent, education of physicians about substantive law can possibly be helpful in reducing this type of defensiveness and may facilitate patients' preferences being implemented. I don't want to push that too hard, though, because there's also this other aspect that states are moving more toward adopting the clear and convincing evidence standard, and it's not clear which way states are going to go, because a lot of states have started doing that, especially after the Cruzan decision came out, and also after the Shivo situation. A lot of states have gotten sort of activated at the legislative level about this, and whereas clear and convincing evidence used to be a minority of states that required it, now it's really becoming more and more the trend as far as legislative changes. So it's not clear what's going to happen. However, it is, I think, reasonable to say that the problem in New York is not necessarily the clear and convincing evidence standard, but the way that it's applied. And I learned just recently from a student in my public health law class who happens to know the judge who authored the opinion in the O'Connor case, Saul Wachter, who must be a real character. But I found out, if this is true, which I tend to believe, he had had a health scare with his mother 2 years before this case arose. And it turned out that she was deathly ill from an unidentified source at this point, at least not to me. And she had said, no, I just want to die, let me go. And he said, no, Mama, you know, we're going to do everything we can. And despite the fact that she was critically ill and wanted to die, was requesting to die, she did get better. So his experience was colored by the fact that she was requesting this, and she survived to, I think, have pretty good function for another few years. And so this student was saying, well, this could really have affected his decision-making in the O'Connor opinion. And I think it's possible that that could have happened. So I hesitate to say we should hope that that woman had died, but New York law would have probably been a lot clearer if that. He might have thought, he actually thinks, apparently, according to the student, that he did make an incorrect decision in that case because of the implications.
Not to mention that he was a disobedient child.
Right. It also creates lots of opportunities for discussions about the Jewish son-mother relationship, which we won't go into either. Others of you out there are much more adept at discussing that. So I think that we can say that there's good news about the role of education, and most states really don't have to deal with this problem at this point. But I do think that there is still a group of physicians who are less conversant about the law and who may practice conservatively in that they are less inclined to agree to a family's request to stop treatment unless they are personally very convinced that the patient wanted that. We actually had a case earlier this year in our ICU of a woman who either had a really good lawyer or she was very thorough, because her advance directive actually said, if I am ever irreversibly in a state of profound dementia, I refuse hydration, nutrition, everything except palliative care. And it turned out that our physicians in that case were even then too paranoid to stop treating her because her children were demanding that they get treatment. So there's a disconnect between what the law permits and the way clinical practice actually emerges. For those of you who are familiar with the Glucksberg and the Vaco opinions on assisted suicide, the U.S. Supreme Court opinions, there's an interesting opinion by Justice Breyer near the end of that, in which he bases his concurrence with the majority, saying that essentially we're not going to recognize that there's a constitutional right to assisted suicide and therefore these states can make these laws. We're going to allow those to be upheld. He said that his rationale was based on the fact that they were assured in the brief submitted to them that there was adequate pain relief available, that the laws of the state did provide for good pain relief, and that they would be implemented. And I added the "and they would be implemented" part, because he doesn't address this fact of the disconnect between clinical practice and theory. Because I think that's where the real interesting questions of decision making arise. Because as we all know, Dr. Dukas and I were discussing yesterday a physician whom we both know who was inappropriately disciplined by a state medical board for prescribing too many opioid analgesics for patients in severe pain. And we have an older generation of physicians who actually tend to believe that there is a ceiling dose for opioids in patients. Fortunately, I actually gave our medical students in public health law a little quiz seeing if they knew that there is no ceiling for that, and they did, so I was actually quite pleased by that result. But it's an interesting thing to examine is when you keep in mind what the theory of the law is, it may make sense, but if it can't be implemented in practice because of these misperceptions or because of other anxieties among the physician population, it still may have the same negative impact for patient care. So that concludes my formal remarks, and I'll be glad to entertain questions if you like. I have some citations from previous work. Yes, Steve?
Well, a simple question, or perhaps not. Your description, or your student's description of the judge in the O'Connor case sounds strongly like there was a conflict of interest in this case. Should he have recused himself from making that decision? Well, that's obviously an opinion question, but it's kind of a legal opinion question.
Yeah, it's an interesting question. The question was, is there a judicial conflict of interest considering this recent experience? And my understanding was it was about 2 years before this case came up. And I think there certainly could be a coloring effect from that, but I'm not sure that the conflicts of rules in legal ethics would require that. Mark, do you happen to know an answer to that?
I don't think so, because
I don't think so either.
For him personally, I mean, everyone has a relative who's died.
Right.
And it could have been the other way. So,
right.
And of course, as a justice on the state's highest court, it's a non-reviewable decision whether the recusals.
Right. Others?
My question pertains to how you define the fact that they were making decisions based upon their knowledge or lack thereof of the law, as over against other factors that may figure in their position.
Right. Yeah, I hope maybe I wasn't sufficiently clear, but I wanted to make clear, if I didn't, that what we're discussing is associations between these variables. And I'm not implying a 100% causality, because I think that would be inappropriate. I do think that there are a lot of other factors that would be in play in this, but we do believe strongly that there is this association and that it is significant and has an effect on the overall decision-making process.
I would like to ask about, to come into Kentucky and to talk about another state's dysfunctional legislature might be a little far.
You want to compete with me on that?
Well, of course I'm teaching. Last week we looked at Quinlan and Kuzan, and DeGrella is the Kentucky case, and then jumped up to Scheibel. And most of the law review articles that I read about Scheibel compliment the result, especially on separation of powers and from a constitutional standpoint, but all predict that it was negative because it has produced popularly this trend that you seem to be seeing, that that this woman whom her mother said was responsive was actually killed by a husband after her money or whatever, and the factual situation didn't help that case any. But there's this is there something in New York that is even more conservative than much of the rest of the country towards the right to life,
Well, it's different, actually. New York, as you know, or should know, is an extremely diverse state, ethnically, religiously, and it's also a state where no one is shy about asserting their interests. I say that very diplomatically. Another way to say that was that they're really pushy. But I think a large part of the reason that there's been no movement in the last decade and a half on this question is that every time one of the particular special interest groups gets their questions remedied, somebody else comes to the fore to raise another objection. The original complainants about this legislation were two groups. First, the Catholic Conference in New York, which was headed by a very strong archbishop in New York, and also the Orthodox Jewish community in New York, both of which have great political power in the New York political process. After a number of years, the Orthodox Jewish community withdrew their objections, and I'm not quite clear on why they did that, but the Catholic Conference has been solid in their opposition until that particular person who was leading them died, and that the proponents of the bill thought might have opened a window of opportunity, a sort of a policy window, to get some change made. And in fact, the Catholic Conference has sort of softened their position on that bill a little bit, but they haven't completely withdrawn it. Their complaint is that it does not provide specifically for a woman who is pregnant at the time the decision needs to be made. So they're actually concerned that fetal life be protected in utero if the woman, it's a medically unrealistic expectation.
And for Catholics, there was a very, I consider, a very unfortunate statement from John Paul II shortly before he died, which seems to reverse what Pius XII and what others had said
Absolutely.
for 50 years.
Yeah, that didn't help. There's no doubt about that. And recently, then, the new wrinkle in this has been, with the rise of same-sex marriage and that type of issue, the Senate of New York, which tends to be strongly Republican, has a number of members who would not accept a bill that allowed persons in a long-standing relationship, same-sex, to be listed as persons who would be authorized as agents under healthcare proxy. So what they wanted to do is have it similar to a lot of other things, which is, spouse, adult child, etc., down the list. And when you run out of relatives like that, you have a designation of close friend or something like that, which would include a same-sex lover. And that seemed only fair. But these senators would not allow the bill to go through under those circumstances. So it's sort of like whack-a-mole. Every time you get one down, another one pops up.
First time we've heard that on a huge lecture. Yes.
Whenever the patient has an advance designated legally a healthcare decision maker, what restrictions does New York place on their consideration of making a decision? Is that subjective judgment?
Well, the only requirement is that they make the decision that the patient would have wanted, as far as they are able to determine. So they are not to offer their own opinion, but they are there as an agent to facilitate the patient's preferences. So if under the law you have evidence that the patient wanted something and the agent is demanding something completely different, it's possible for the institution to go to court to get the agent disqualified. That would have been the next step in the case I mentioned to you that we had. However, our institution has been under great scrutiny from the Department of Health and the local newspaper, which is a real muckraking sheet. And so the wise lawyers in the legal counsel's office decided they didn't want more heat. So going to court to try to facilitate this woman dying in the hospital probably wouldn't be perceived as a great idea under the political circumstances.
I had one brief comment about that case that you told us about, and then a more general question. comment is, I wonder what the response would be of the hospital staff if the clever lawyer added an additional sentence that said, I also hereby direct the administrator of my estate to review my medical records and to institute legal action against any doctor who has failed to follow through with my demand that treatment be withheld, and even list the various causes of action that could be brought. So I wonder whether the docs might.
I'd like to raise
I expect that would get their attention. But physicians do tend, I think, only see one side of this equation, and the same is true with opioid analgesia delivery, because I'll let you do it. The question in a nutshell, I think, is what if the lawyer, in drafting that careful and detailed healthcare proxy, had also directed the survivors of this patient to sue the physicians for not following her wishes in those cases. And in the Oregon opioid cases are interesting because in that case, the Board of Medical Examiners there has been very active in trying to ensure good pain relief. Physicians there were following the trend of a lot of other states formerly, whereby they would prescribe less morphine rather than more in order to be on the safe side and avoid causing the patient's death. What happened in Oregon was that a number of patients' families actually did file suit against physicians in Oregon on the grounds of inadequate pain relief. And that was held, I believe, by the Board of Medical Examiners to be valid claims under certain circumstances, and some of those physicians, I believe, were disciplined. Some of you may know more detail about that. But it is, I think, quite plausible that something like that could be a balancing effect on this type of analysis. The question is, does that create more paranoia or less, I suppose, or maybe paranoia is a good thing.
The question I had, Ben, is the following. I think the data makes it very clear that more knowledge results in more rational behavior by physicians. In New York, the rational behavior is to be scared to death of this law.
Right.
In Texas, it's to be more willing to cede some of the decisional control. In my experience, that same result applies no matter what issue we're talking about. I mean, it goes well beyond end-of-life issues. If you talk about informed consent, if you talk about privacy, a privacy rule, whatever legal issue. And so the question that I have is, have you given any thought to the best way of trying to improve physician knowledge of the law and to demonstrate the direct relevance to their medical practice and so on?
Yeah, the question is, have we considered ways to improve medical education to take into account these types of behaviors? And we have given thought to that. The question is, at one level in medical education, medical students tend not to believe anybody who talks to them if you don't have an MD after your name. There's an automatic credibility problem. And unfortunately, it doesn't seem to be substantively specific. I think that was one of the interesting things about our previous research, finding that physicians who got none of their other information from doctors did much better. But I think it does suggest that physicians, I think some other professions may do it as well, but they view people in their own profession as knowledgeable about a wide variety of things about which they may know nothing, or about which they may be horribly misinformed. So, in fact, if you tell medical students certain types of things about pain relief, they don't even believe doctors sometimes. One of my close colleagues, Jack Coulihan, who's an experienced practitioner, long-time treater of patients, he's going to be retiring soon, but he gives a lecture every year about the actual risk of prosecution by the Drug Enforcement Agency for prescribing adequate opioids for patients in severe pain. And the students routinely sit there and you can see that they're going, yeah, right. So that there is sort of an institutional barrier, I think, to this. I think that would be a very interesting topic to try to research further. Sort of how do we tweak medical education about the law to overcome these barriers? And I don't really have a lot of great ideas about that, but it might make David's nodding here, so that we could concoct a good research project. Yeah, thank you, Mark.
You talked about civil and criminal liability. The students I've had, I think one of the further problems is these other folks risk licensure. And the license board might be much more strict than the court is going to be. And you can lose your profession.
On what topic are you raising that? End-of-life decision-making?
You didn't give enough opiates, you gave too many opiates. You have to face the license board. And the other one that always comes up that I've learned about on the ethics committee that I hadn't given adequate thought to was risk management. Is the hospital going to accept this? If the family is making a clamor that they want treatment, it seems to me the hospital has to start thinking, we have a license on the line, we have lawsuits on the line, and do we want to get into this, that we kill incompetent old people? And that's
well,
so I think there are other pressures towards...
Well, first of all, you're not killing them.
No.
But there could be...
The Courier will, the headline in the Courier will...
Right, and that I think highlights the role of the media in these issues too, is because they generally are very uncritical about these things.
Yeah.
They're uninformed, and they jump to conclusions like that, which create problems of public perceptions. So that's a serious problem, I agree. I think it's less of a problem with refusal of treatment than it is with opioids, though, since the politics of that is...
I have a general legal scholar question. Has there ever been a case which raised the issue of pregnancy, in which a terminally ill pregnant woman who signed a living will, where she or her proxy said, okay, it's time to execute this, implement this living will, where this actually came into play? Has there ever been a case that anyone here in this room has heard?
Yeah, the question is, has there ever been a case where a pregnant woman who had an advance directive seeking to refuse treatment, where that was brought to trial, or at least involved in the legal system? I seem to recall that there have been a few cases. I don't know how far into the judicial system those cases penetrated. Does anybody know?
I recall that it was a GW where a woman had a cancer and she wished to stay alive, and her husband sustained that wish so that the child would be born.
Right.
But I can't ever recall one where this specter, this boogeyman, which has always been raised for advance directives, has actually come into play.
I think there have been one or two, but it's purely...
And I'd like to know the citations for that.
Yeah.
The question was, we actually had a bill introduced into the Kentucky legislature about clear and convincing evidence that I recall fell down on itself. It never went anywhere. But there was a House bill that was introduced about having a new advance directive document which would require clear and convincing
That was in the
evidence.
post-Shivo era, I'm sure.
And that was thank God that never went anywhere.
Yeah, that was a good thing.
One of the things that I'm interested in is what do you do in a clear and convincing state? And I lived for 10 years in Michigan, where with the Michael Martin law, the case, they had that go into effect. One of the things as a clinician that I was able to go ahead and do is use that to positive effect. Michigan is a fairly conservative state, at least where I was practicing. And one of the things that I was able to do was to ask them a very real question as to whether they wish to have their own family make their decisions based on their own values and their own preferences to the best of their ability, or would they instead prefer that the state make their decisions for them? And people were very quick to go ahead and say, I don't want the governor, I don't want the state to make my decisions. I said, then here's your advance directive form, have this executed, bring it back to me, and I'll put a copy in your charter.
Right.
And people were very willing to sign their advance directives.
Yeah, I bet.
And so part of this also goes into the position aspect of it too, though, is that, again, the ignorance part of this, especially since we were doing a survey on Jack Kevorkian at the time and his interesting behaviors, we decided by extension to ask oncologists how often they had participated in assisted suicide.
Mm-hmm.
And we asked a range of questions, sort of sliding them up and down the slippery slope. Things about, have you ever participated in an act of euthanasia? Have you ever prescribed a prescription? One of the questions was what a physician would do when a patient who is competent requests to discontinue a treatment which is sustaining their lives. This is statewide, so we had every single oncologist, we queried every oncologist. We had like a 57% response rate. 21% of them said they would never discontinue life-sustaining treatment, even when competently refused by the patient to murder self.
Yeah, I believe that.
And that's one of the things that was extremely striking. Here's a specific thing saying, I'm not going to stop it, even if they say.
Right.
And so here's one of the questions that I'm now going to sum up with a question. Would it not be prudent then to have a very highly detailed advance directive in such states, because there are like a handful of states that have this American convincing standard, where you say, here's a panoply of things that can be your end-of-life situation. Strike through any of those that you don't agree with where you would want the discontinuation of life-sustaining treatment, and have it appended as part of their advance directive. Because all the advance directive, as I understand it, except for a handful of states on the West Coast, they allow for you to append your advance directive with any statements that are then adhered to that advance directive. So would it not be helpful to have something that says, if I'm demented end stage, if I wind up in a circumstance of irreversible coma, if I wind up with terminal illness following cancer, heart disease, or a renal disease, where you just go ahead and make it such a blanket document where it will then say, no matter what, I'm covered to the best of your ability.
Well, that last qualifier, I think, is the key factor, because I've tried to do this a number of times and have failed miserably. It's extraordinarily difficult to predict the array of circumstances that you could find yourself in. So the majority of bioethicists would recommend, I think, still that you have a proxy decision maker who knows you well and can advocate your values and is willing to go to bat for you.
Well, thank you for that part of it, because that was the follow-up, which is, would it then not be more prudent then for someone to have a more specific articulation of their values rather than their scenarios, and then tether them to that of a certain decision?
Yeah, I actually think that's a very helpful.
Is one of the things that I'm
right.
I
think that's more helpful than trying to create a laundry list. If you describe your approach to life generally, that can be used as evidence to support the family members' decisions in those cases.
So the only thing that really needs to change without making the Catholic Conference go ahead and turn upside down on their head would be to say, if we don't, what we could do is have a new law structured where at least if you have evidence that this would be counter the values and preferences, or values or preferences of the patient, without saying in this specific circumstance. So that at least you would be able to go ahead and have a values construct rather than a scenario-based construct, since we never know how it will be.
I think that's a good point, but that still doesn't cover the 75 or 80 or 90% of people who don't have one at all.
I hear
so
you.
that's your issue. I want to respond also to your question about clear and convincing evidence, because I think the answer to that is dependent very much on the individual judge who's hearing the case.
Yes.
How that person is going to interpret the standard, what that person's political ambitions and motivations might be. There's all sorts of ways that could be misused, because those of you who know the Cruzan case well will know this, but the Supreme Court actually remanded the Cruzan case back to the original trial court for additional testimony. And more of Nancy Cruzan's friends came. They recounted more about their conversations with her. There was a wealth of evidence, and the same judge reached the same conclusion, which allowed her feeding tube to be withdrawn. So even in Missouri, which has the clear and convincing evidence standard, the judicial process worked to facilitate that under those circumstances. So it's highly dependent on the judges and the political climate, I think.
Yeah.
A kind of a simple-minded question. If a family would wind up in New York in this type of situation, what's the feasibility of moving the patient to a more permissive state? I realize there would be the medical aspect of whether the patient could be transported.
Right.
But if the patient could be transported, is that a...
I think that's again a question that's going to have the general answer that it's going to depend on the individual institutions involved. Because you may recall that in the Cruzan case, the patient, Nancy Cruzan, was in a state-sponsored skilled nursing facility. Her family asked for her to be transferred to another state. The state said, no, we're holding her captive until we get this judicial decision. So if persons are intent on pushing this, it's, as you know, it's difficult enough to transfer a patient when all things are going right. But if there's resistance, that can make it much more difficult. So I think it's a great idea, but it's impractical to count on that as a solution to the problem. Stephen?
Well, I'd actually like to ask, going back the other direction, there is in Texas law, if I remember you correctly, there is a best interest standard attached to the end of, once you've run through your list of possible surrogates, then you go on to best interest.
If the patient has not expressed preferences.
Right. Which certainly makes sense in that that's the only thing you've got left at that point.
Right.
But who's making that decision? And the reason that I ask is it seems like there is here's this catchphrase, but there's a conflict of interest for physicians making that decision, particularly if they're making that decision for a patient with no insurance, who's costing them a lot of money in the ICU, blah, 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 blah. Are there any protections available for patients at that point to have it really be, how do we say, their best interest, somebody advocating for their best interest?
Yeah, I think there are, because as you may know, there was a case in Texas within the last 18 months involving that type of situation, where the family were trying to object to the physician's determination that further treatment was futile. And that patient actually ended up being transferred, I believe, to Michigan. Does anybody from Texas know the upshot of that case? I know Bill Winslade in Galveston was involved in that case, but that was a case where the Texas Medical Center futility policy was directly challenged, I believe, saying that you're physicians and you have just the conflicts of interest that you described, and we believe this is inappropriate, and we're willing to move the patient and take other actions. And the physicians, I think, were trying to push the point, or maybe it was the institutions who were trying to push the point. So there was a lot of behind-the-scenes negotiating, I think, which eventually resulted in that patient being transferred. With respect to the issue of resource allocation, though, I don't think that's really a pressing issue, because institutions are so sensitive to the risk of being perceived as cutting off someone because of inability to pay, that it's really hard for them to do that. I've never seen institutions usually when you even mention that, they go running and screaming into the distance going, no, we never do that.
Institutions maybe, but not the physicians.
Right, yes. Physicians may want to promote the idea that institutional and professional integrity requires them not to be obligated to deliver care that they believe is ineffectual. And that's the crux of the futility argument, which is still quite alive and well, and I think the Texas Medical Center policy is precipitating it to some degree. Yeah.
I'm very interested in this issue of the dynamics or variables that go into decision-making, whether at the end of life or in the clinical setting. And I take it from your presentation that one factor, though maybe not even the most important factor, is knowledge of the law. And I think, for instance, of the irony there in New York State, it's very strong anti-assisted suicide law, and in which Timothy Quill did assist a suicide,
Right.
and in which the Attorney General did not file suit against Timothy Quill in spite of the Baco v. Quill decision.
Right. A grand jury did meet and chose not to indict Tim Quill for that action. Right. It was interesting. He gave a talk at our medical school a few months ago, and someone asked him, if you had it to do over again, would you still do the same thing? And he had to think about that for a long time, because he said, when I did it, I didn't really appreciate fully how much it would wreck my life temporarily. You know, going through that judicial process was so stressful that I think he was glad he did it on the back end, but it was extremely uncomfortable for him. That's why I think one of the issues related to this perception is that physicians generally perceive just being sued as punishment itself, even though it doesn't mean that there's any fault finding or any money's going to be paid. It's such a stressful activity that it is perceived that way. I read a fairly simplistic article in some fly-by-night journal that somebody forwarded to me by a neurologist who was asking the question of, will telling patients the truth reduce lawsuits? You know, his question was, will it reduce the risk of being sued? And that prompts me to make the comment that I make to medical students all the time, which is, what does it take to sue somebody? And they don't really realize that all it takes is, you have to have a computer to send your electronic filing, and then you have to have enough money to pay the filing fee, and then you have to enough money to pay for the service of the complaint on the defendant, and so that's it. I mean, it doesn't take anything to file a suit against somebody. So they're essentially asking the wrong questions in that respect, but it's nonetheless this anxiety about the personal implications of that do have a significant impact on the overall decision process, I think. So that's another fertile area for research, I think, if you could get people to talk about it. Yes, sir.
Where does Kentucky fall in that continuum as far as you know?
My understanding is that Kentucky is a preponderance of the evidence state. Is that right, David? Yeah. And I would also expect, even though I don't know factually, that there is a priority statute which enables persons without advance directives to have a family member make a legal decision for them.
That's the way we talk about living wills in that context. That's what I
Right.
thought. But the other question...
Actually, there's a lot of physicians in New York who think we have the same, but we don't. So.
My second question is, how does it practically play out in that ICU room where nobody is really there with the physician and the patient and maybe a family member? I have a hard time believing that burden of clear and convincing evidence is always scrutinized. I mean, does the physician say, what do you think, Aunt Jane wanted, and they tell you what they think Aunt Jane wanted, but nobody ever really...
Right.
I mean, the challenge is...
There's a lot of leading questions that go on in that kind of thing. Aren't you sure that Aunt Jane would have, didn't you have a conversation with her? You must have had a conversation with her. Surely you did have a conversation with Aunt Jane. And then they kind of get it and say, oh, yeah, right, and let me tell you about our conversation. It's highly dependent on the individual institution. I can tell you, because it's not a huge secret, that our institution essentially ignores the law on those types of things and tries to do the ethically appropriate thing for the patient care and to facilitate the patient's wishes. There are other institutions that take a much harder line approach. So whether the degree to which that will be enforced in New York is highly dependent on the institution in which one finds oneself.
Do you have a futility policy in the hospital?
No.
Just curious.
Yeah. Well, we've actually had there's an Attorney General opinion that Elliot Spitzer drafted recognizing that futility was not a legitimate legal grounds for refusing to comply with a family's demand under the existing laws, under the O'Connor case. So we've got an Attorney General opinion.
Actually
Yeah, no, he's screwed us in more ways than one. It's like I keep trying to get, I look at his website because he's running for governor now. I keep trying to figure out what's his real opinion on this law. What does he think about it? Does he want the Family Health Decisions Act to pass or not? So.
I teach the other side. If you have a real problem about dying in Kentucky, the best thing would be to become a ward of the state. The state will never terminate treatment.
Oh, yes.
Yeah.
So it would become ward.
Right.
Dr. Quill came here, and when he talked to the Jefferson County Medical Society, the thing that stuck with me is before you open your mouth, make rounds with me. And that's what I learned every month at the Ethics Committee meeting.
Right.
I've never been at a bedside. I've never been with a terminally ill patient with all of these conditions. I've never had, it's easy for me as a lawyer, as an ethicist, to pontificate. But as you say, when you're in that room with the door closed to the patient and one family member, it's a quite different world. A lot of these
It's also very psychologically loaded for physicians, even if they agree with the patient's decision, to make the actual decision to stop. It's just a very difficult human thing to confront. And some physicians are more willing to confront that than others and work through the difficulty.
I think we are done.
Okay.
So
Thank you very much.
Thank you.